Welcome, I'm Sue Flockley. I'm from the Prevention Research Center for Healthy Neighborhoods here at Peace. Welcome to you all. This is our Wednesday seminar. It's the second Wednesday of the month at noon, and many familiar faces. If you are new and have not been here before, I do invite you to sign up and let us know who you are, where you're coming from, and what your research, interested in hearing about your research. This helps us know who's coming and have a way to reach you for future presentations and also special events that might be of interest to you. If you have ideas for presentations or recommendations for speakers, I certainly welcome those. Please send those to me at susanflockley@pace.edu, and I can stick around too if you have some ideas or suggestions. We have, I'll give you a little preview. You've probably seen the list of talks. Next month we'll hear about the Little Cigar Study, and Elizabeth Antonelli will be presenting and probably doing this as a tag team on some early findings from that study that we're excited to tell you about, and you've probably heard some bits and pieces along the way. I don't think I have any other big announcements. Oh, tweeting, live tweeting, that's what I was supposed to say. We are live tweeting. So for those of you that are that tweet, we are live tweeting using the hashtag PRCHN seminar. So if you have ideas and you want to share it and get it out there, please feel free to do that. We would love to hear your ideas and comments and get that word out. These talks are recorded for future viewing for people who aren't able to join us in person. And those are available on our website, and you can find them under seminars. So to today's speaker, it is my pleasure to introduce Madalena Monteban, who is with us right now as a postdoctoral scholar working with Darcy Friedman and her team on the FreshLink study. She has a degree in medical and cultural anthropology from the University of Georgia. Is a recent grad, and we're delighted to have her contributions, particularly around qualitative analysis and qualitative data collection on the phase of the FreshLink study that's going on right now, which is involving conducting qualitative interviews, conducting analyses around food habits. The work that she's presenting today is drawn from her dissertation work, and should be really interesting, and I think we're going to get some great pictures from what I've seen. And the title of it is Maternal Knowledge and Child Health, the Case of Infant Growth in Peruvian Andes. So we look forward to the talk. Thank you very much.
So thank you so much for being here on such a beautiful day. And it's hard to get inside when it's so nice out. And I was going to do some self-introductions, but since that's already kind of out there, I would just go ahead and necessarily as important. And rate for age wasn't either. They were mostly concerned about stunting rates. So I don't necessarily have the data or the numbers right here to compare within this population with children overall, but it seems from what the public health staff were telling me that it would be comparable.
Just one more question, sorry, I'm just very excited. So you were also talking about power inequalities. I was wondering, did you notice some sort of power inequalities within the household? And I'm basically drawing from my experience, because mother-in-laws in India especially have a say on how a grandson or a daughter is fed, even breastfed. So did you notice any kind of those kind of struggles within the household, or like extended families? Was there a concept around that?
There was definitely certain things that you would get not reprimanded, but you would be called out on by older generations or by people who maybe follow like traditional beliefs or something. Like for example, breastfeeding should stop at 1.5 years. And if you continue to breastfeed, then you're affecting that child's personality into the future, because they'll have a big heart, is what they say, and they'll be more tend towards violence as a grown-up.
Contradictory, big heart, but big heart.
Yeah, big heart, but big heart with like
You can't control yourself.
yeah. So certain things, yes, they would be like, well. I was actually breastfeeding my child when I was there, and I would, experience these comments from people, and they get to you. They do get to you. I was experiencing even comments from public health because my child was also short for his age, so I was getting it from both ends. I was like, I'm not doing anything right. But
But that's an interesting point around the gender, the way that women are held responsible for these things as well, that it is their responsibility and it's their fault. And I think your comment just then was like, and I'm not doing anything right. So both sides sounds like have a potential to oppress.
Yeah, true. Yeah, and there was, infant mortality while I was there and experienced that and watched what happened, in that case. And, there was mother blame. Like, why did you not go and why did you not seek, she brought the infant to the hospital, but they didn't pay attention to her. But it was still her fault, she should have, demanded attention at that time. So, yeah.
Did you, is there anything about birth order and difference in stunting?
I did not look into that. It's good. Something to consider,
Just
for sure.
confidence in the mother in those do things completely different between the first and the second.
Yeah. Public health staff definitely talked about first mothers having more difficulties with breastfeeding, and then more experienced mothers not having that issue. But I don't know about stunting in relation to birth order, but it's. Yes, Sarah.
I just had a question. When you were looking at or doing the semi-structured interviews or the participant observations, did you notice or did your study attest to whether the ability to actually follow public health recommendations plays a role versus just going with the traditional knowledge? So you showed the picture of the food that had just a little bit of meat on it, and in rural communities like my work, when I've worked in Central American rural communities, meat was they rarely got it because it was not readily available. It was very expensive when they did access it. So is it something because of that, or is it more because they're trying to attend to the traditional views of what a child should be eating?
No, definitely it's much harder to access. Meat is, they have livestock, they raise sheep, they raise cow and guinea pig, but meat is just a luxury. And in order to get more meat in the diet, killing an animal for food versus selling it is, a big difference. And then there's no refrigerators. If you wanted to go and buy, meat for the week, you can't do that. It's it just doesn't make sense. So you'd have to buy it daily. There are processes of conserving meat, actually, freeze drying meat, so that's possible. But it's just there's a big issue of access as well. Yeah,
Do you think that
and
women would have, if they could, would they have brought in more of the public health recommendations in terms of those feeding practices?
I think there's instances, yes. And there's also instances this is the way we eat. This is my food doesn't include a big portion of meat. I like my soup the way it is. I like my stew the way it is. And I eat meat on special occasions. So it's both like a cultural and access issue, I think. Okay, cool.
Similar to Sarah's comment, when moms were insisting on feeding their kids complementary feeds at 4 months, do you think that could be due to WHO's earlier recommendation of actually starting complementary feed at 4 months, and then subsequently they changed their recommendation to 6 months? Could there be a spillover effect of that recommendation changing in between, or?
I don't know if they ever got the recommendation of 4 months. I think it's been like consistently, as far as I know, 6 months. So I don't think I would. I'm not a historian, and I didn't look at like the archives and see like the whole picture of like public health recommendations. So, but my feeling is that it's been 6 months, especially because. I guess I've only been looking at this new initiative, so. And mothers didn't necessarily talk about like, oh, it's at 4 months, it's at 3 months. They talked about it's when the infant is telling me. When the infant is looking at my food, and my child is looking at my food and wanting the food and not like spitting it out, then, he's hungry and he's eating it. Yeah.
Well, and if even on that point, there are, like, that issue of 6 months is now a lax thing. And so, like, back to the point of the fluidity, even these public health rules are fluid. Mm-hmm. So I think it's now back to 4 months of, introduction. And so how do you... all of these things we hold are continually changing. I mean, especially around food. Like, there's no truth of, capital T, truth of food.
Yeah, and the issue is that I know, because I'm a researcher, I don't know. I mean, I know that these things are just recommendations, and that, like I can do what I want. But it's not portrayed in that way. There's like, it's 6 months or it's 6 months, and if it's not 6 months, then if your child gets sick, and then it's your fault. So the way that it's portrayed and presented is a big thing. And I think there's a difference between the recommendations for underdeveloped countries and developed countries, because there's an assumption that those environments are like there's less sanitary, and they are, because there's the water's not treated and things like that. So they're more sticklers about 6 months because of the sanitation issues too. Mm-hmm. Yeah.
Okay, so please join me again in thanking.
I mean, talking with public health staff, it's kind of pretty for that. I don't have to. I didn't specific, but I didn't talk about it because I'm planning to do it like outside of this. This is a paper, and I think it's an important thing to report as well. And there has been research in different places in the Andes that have found differences in caretaking behaviors between males and females, male and female children, and this was negative for females. So I didn't observe any difference. Mothers didn't talk about preference between males and females, but it could be something that's happening unconsciously or through other mechanisms. Mm-hmm.
Wonderful presentation, thank you. So for somebody who's new to this type of a topic, the stunting measure, you had like 3 tables up there. Then one was weight, one was height, and one I think was the relationship between height and weight. Mm-hmm. So when height and weight was the outcome, it did not seem like there was a problem. Was that the correct
Yes. Yes.
So what does that mean as far as like we look at these universal measures of BMI that are so biased towards Caucasian body types? So here we're using stunting. When is it maybe that they're very different height to start with in the region?
I mean, it could. I grapple with that because, you know, there's the issue of high altitude hypoxia affects growth, right? And so it could be that growth is slower. But I mean, what I'm looking at is that within this population, there is this variation. So there is a I mean, it is significant because there's that variation within this population. So and researchers attribute, you know, like, okay, well, maybe hypoxia has an importance, and they're just in general they're shorter, but within that there's also other factors, nutritional factors, and access to healthcare that are also influencing. So it's not just, okay, in this population there's hypoxia, so everybody's shorter. There's other factors, and there is variation. So I think that nutritional deficiencies are important, as well as these other factors. I don't know if that makes sense.
Excellent presentation, and I was really excited for your presentation because this is the kind of work I was doing back at home, back in India, and so I could relate to all of the difficulties in, you know, trying to understand the traditional knowledge and the public health knowledge. It's in itself is very difficult, especially when you're trying to cluster or group traditional knowledge, because it could be varied. Like each person could have something else to add. So, really amazing job. I just had two questions. When you were talking about stunting and wasting, I believe you were using the WHO growth curves.
Yes.
That are used everywhere. So were you able to look at overall stunting among in your population among kids? Were you able to get a chance? Did you get a chance to look at that when they? Because that's like a nutritional. How is the nutritional profile, status profile of the population?
I mean, I have overall in Peru, right? I think it's, and that's the end of my talk. I'd like to thank my community members and my research. I didn't mention I worked with research assistants from the communities who, because the research was conducted in Quechua, which was the native language of the mothers that participated. They were there doing all the interviews, all the surveys, helping me translate. Even though I am a little bit proficient in Quechua, I wasn't fluent, so they were there throughout the whole process and helping me transcribe and translate the interviews and interpret things as well. I did receive help with the statistics as well, and I'd like to acknowledge that, my advisors and the support that I received. So, yeah.
So I hope we have questions and discussions.
Yes.
Okay. Very nice. This was really a beautiful presentation, and the topic, not only is the topic interesting, but I really do just want to commend you on the mixed method.
Thank you.
I think it really, it's such a good example of that extrapolation of, you know, bringing together all the different pieces that if you had done only one of those pieces, the others would have been missing. So it really does show the merit. I have a sort of interesting question, whether you've already done this. Was there anything within the knowledge questions, like the specific questions, that might have been driving? Like, I know you had, how many, it was, you said, I can't remember, how many items?
40 items for each, so 80 total.
Did
right?
you think, did you look at any, analytically look to see if there, because that would seem like it'd be, then you could do something, right? Is it just the overall knowledge, or is it certain kinds of information that's either contradictory or that could be acted upon, you know?
Has been suggested, and yes, I think it has been on my mind as of late, and I think it would be interesting to look at for sure, definitely.
You have enough sample size that you could probably
100, do I?
80 items. Yeah, but at least enough to give you some way of of sensitivity of the items. Are they all, because they're usually knowledge questions are usually not necessarily related, but were they designed to be clustered in any way?
Yeah, there's like 4 clustering in each of the sections.
So even if you did that and took the right, you made them four scores, and then looked to see if the 4 scores, if one of those 4 drive the. It's interesting. But,
well, thank you. I'll take a note of it. Yeah. Yes.
I loved your presentation. Great job. Very interesting, and I think very relevant here. I mean, the topic of traditional knowledge versus public health, or sort of external knowledge, professional knowledge, and the thing that I grappled with was this, the people that seem to have a little bit of fluidity in their beliefs so that they could hold 2 views at the same time seem to be benefiting in terms of the health outcomes. And I'm curious, it applies a lot for some of the qualitative data we're getting with FreshLink as well, where you see people that have this fluidity in their understanding versus a very rigid structure of their knowledge or their perceptions or their beliefs. And I just was curious to hear you talk a little bit about when you taught or spent time with people where you saw there was people that could hold the tension versus people that felt like they perhaps had to stick with one or the other side.
I did look at behavior, so a big part of the research was also kind of observing and did some case studies. And I didn't necessarily pull those apart, but it would be very interesting to look at for sure. Because I definitely think it's important to see that flexibility as opposed to not being flexible. I think in general, even though women might conceptualize, I think the tendency is to conceptualize still with traditional explanations. But even with those conceptualizations, women were still managing, I'll do anything. I'll go to the traditional healer, or I'll go to public health, if I need to, in order to address my child's health. So there was a lot of managing in both. I can't think of a case where a mom was very rigid. The one thing would be introduction of solid foods earlier. This thing of I follow my infant's cues. My child is telling me that he's hungry, and I believe that he's going to get sick if I don't feed him. So that might be a point to explore. Yeah.
I thought I saw something on one of the tables, but I'm not sure. Did you find any significant differences between male and female?
I did.
Babies?
I did. So I found a significant difference